We have with us now Marina Shirmanova. Marina is a group leader at the Nizhny Novgorod State Technical University in Russia. Her research focus is on the development of methodologies of metabolic imaging of cancers to translate FLIM into clinical use. And today, Marina will talk to us about FLIM of NAD, tumor diagnosis, and evaluation of chemosensitivity. Marina, welcome.
Hello, I'm with
to us about FLIM of NAD, tumor diagnosis, and evaluation of chemosensitivity. Marina, welcome.
Can you see my screen now? Yeah. Can you hear me?
Yes, Marina, can you please close the main stage browser? You are double echoing into it. Please close the main stage, only be in the backstage.
Can you see my screen now? Yeah. Can you hear me?
Yes, Marina, can you please close the main? There we go. Can you hear me now?
Yes.
Yes, and I can hear you without an echo. Please. Nope, you unshared your screen.
Is it okay now?
We see the PowerPoint, not the presentation.
I'm sorry. It was fine in the testing mode. So I don't understand what's wrong now.
No worries. I mean, you can unshare again and share against screen one to be in the presentation mode. Can you go in the reader mode? This will be sufficient.
Is it okay now?
Can you go in the reader mode, please?
Okay.
Down at the bottom. There we go. Please, start yours. Welcome.
Hello, everyone, and greetings from Russia. It's a great pleasure for me to join this workshop. And first of all, I would like to thank organizers, especially Dr. Wolfgang Becker and Holly, for the kind invitation to speak here. It's a big honor for me. I'm going to tell you a little about fluorescence lifetime imaging of NADH for tumor diagnosis and evaluation of chemosensitivity of tumors. So here is the outline of my talk. I will start with a short introduction into the topic of cancer metabolism. Then I will describe the instruments we use in our studies, and then I will share some of our results with you. First part will be about differentiation between tumor and healthy tissue using FLIM of NADH. And in the second part of my talk, I will speak about monitoring of tumor response to chemotherapy using FLIM of NADH. And then I will finalize with some conclusions. It's well known that cancer cells have specific metabolism, and the most recognized feature of cancer metabolism is increased glycolysis. Glycolysis is a fermentation of glucose without oxygen, but cancer cells, unlike normal cells, use glycolysis even in the presence of oxygen. This is so-called the Warburg effect. Oxidative glucose metabolism can be decreased in cancer cells or at the same level as in normal cells. In addition to glucose, cancer cells use different substrates to generate energy, like fatty acids or amino acid glutamine. And being in different environment, microenvironment within tumor, different cancer cells have very different metabolic profiles and can easily switch between different metabolic pathways to adapt to unfavorable conditions, for example, to hypoxia or nutrient starvation. How to visualize, how to measure metabolic state of living cells? One of the ways to do this is to use fluorescence from endogenous metabolic cofactors, reduced NADH and oxidized flavin cofactor, FAD, both act as electron carriers in a number of biochemical reactions, and primarily in the reactions of energy metabolism. And thank you, Angelika Ruik, previous speaker, for the detailed introduction into biochemistry of all these molecules. So an ADH in the reduced state is produced during glycolysis and the CCA cycle, and it's getting oxidized, that is, it is consumed in the oxidative phosphorylation process in the mitochondria. And normally an ADH fluorescence decay is best fitted with a B-exponential model, in which the short component is attributed to free NADH and a long component is attributed to NADH bound to enzymes with small variations in the fluorescence lifetime depending on the enzyme. And speaking about NADH, I should mention about phosphorylated form of this cofactor, NADPH, which has longer fluorescence lifetimes than bound NADH, but it is present in cancer cells normally in very low concentration, undetectable by fluorescence lifetime imaging. FAD in the oxidized states is another fluorescent cofactor. It is produced during oxidative phosphorylation, and the intensities of fluorescence from NADH and FAD allow us to calculate the optical redox ratio, the metric that reflects the general metabolic activity and the redox state of the cells. So fluorescence lifetimes of NADH is specifically the ratio between free and protein-bound fraction, and the intensity-based redox ratio are the main parameters that we measure in cells and tissues in our studies. Currently existing fluorescence lifetime imaging systems allows to visualize metabolic states at different level, from subcellular to the level of a whole tumor. We will have subcellular resolution by using 1-photon or 2-photon excited FLIM microscopy and rather systems, microscopic systems suitable for clinical use, like shown here from Lab company, Germany. You can also do point spectroscopic measurements of fluorescence lifetimes in the tissue using fiber-based techniques within systems with a needle probe that can be easily inserted into the tissue to have the signal from the tissue depth. And also you can use a macro-FLIM system to visualize a whole tumor in mice or quite large piece of excised tissues. This is macroscopic FLIM from Becker-Hickel company. We have all three systems in our institute and use them in our studies. Why do we like FLIM? Why do we prefer FLIM for metabolic imaging? Because like all the other optical techniques, FLIM is non-invasive. It allows to probe metabolism in live cells and tissues in real time and directly observe the parameter you want to measure. Unlike fluorescence intensity, fluorescence lifetime doesn't depend in a certain degree on concentration of the fluorophore, which is especially important when you work with tissues in which distribution of the fluorophore normally inhomogeneous. And also fluorescence lifetime is sensitive to molecular environment of the fluorophore. It can be, depending on the fluorophore, it can be a pH or viscosity or temperature or proximity of acceptor to donor. But in the case of an ADH, the binding to proteins is a main factor that changes its fluorescence lifetime. So now I'm moving to results and show you the results that are related to tumor diagnosis. In one of our first experiments using macroscopic FLIM system, for the first time we visualized an ADH fluorescence lifetime at the level of a whole tumor. Here you see the colorectal cancer inoculated on the mouse leg, and this was done in vivo. You see the picture of the mean fluorescence lifetime of an ADH and the ratio of free and bound NADH fractions. And in both FLIM images, you can differentiate easily tumor from surrounding tissue, muscles, and with a tumor having shorter mean fluorescence lifetime and increased contribution from free NADH fraction, the indicators of more glycolytic metabolism in the tumor. But of course, there are a lot of tumor types, a lot of situations when the tumor cannot be accessed with such technique. So we also can image autofluorescence from NADH in the excised, freshly excised tissue samples. And this was done, for example, for glioma tumors. You know that glioma is one of the most aggressive tumor types. And in neurosurgery, it's a huge problem to identify tumor boundaries during in the course of surgical operations. So this is why we tried to do this with macro-FLIM. First, on the rat glioma models, we used 2 models of gliomas implanted in the rat brains. This was anaplastic astrocytoma, less aggressive one, and glioblastoma C6, the more aggressive tumor. Here you see the FLIM images of the whole rat brains with the tumor inside. Tumor is shown by the circle. What we found here, first, when the tumor grows in the brain, it modifies all the fluorescence lifetime parameters of normal brain tissues outside the tumor. So we compared fluorescence lifetime parameters in the spectral range of NADH between tumor and surrounding tissues, and also between tumor and normal brain without tumor. So what we see here, what we saw here, is that anaplastic astrocytoma can be differentiated, can be distinguished using FLIM from surrounding tissues and from normal brain. Unlike glioblastoma, glioblastoma has identical fluorescence lifetimes as normal tissues. So in principle, this experiment shows us that it is possible to use FLIM to differentiate between glioma and normal brain tissues. An interesting observation here is that although we used excitation and registration in the NADH spectral range, the fluorescence lifetimes that we detected in the brain tissues, both in the tumor and normal brain, were much longer than those typical for NADH, with T1 around 0.8 nanosecond and T2 more than 4 nanosecond. So we can only assume that some other fluorophores contribute to autofluorescence of the brain in this spectral range, in addition to NADH. We don't know exactly what they are, but from clinical point of view, it may be not that important what is the source of autofluorescence and what biochemical process is behind it, but it is more important that a tumor can be distinguished from normal tissue. So the next step was to look at autofluorescence from patients' samples. So we had here surgical samples of glioblastoma and the peritumoral white matter. Among the samples of white matter, there were some samples infiltrated by tumor cells and some samples without infiltration by tumor cells, or with a very small amount of tumor cells inside, according histological analysis. And what we found here is that mean fluorescence lifetime didn't differ between these types of the samples, but the ratio of the short and long components did. And you see here that the ratio between A1 and A2 did differ between glioblastoma and the peritumoral white matter without infiltration. But if the white matter contained large amount of tumor cells, it didn't differ in fluorescence lifetime from the tumor. So in principle, glioblastoma could be differed from non-infiltrated white matter, and this shows the potential of FLIM, macro-FLIM, for intraoperative diagnosis. It's very exciting results for clinicians. Differentiation between tumors and normal tissues can be done not only at the macro scale, but also at the microscopic scale. And in this study, we analyzed autofluorescence and ADH autofluorescence in colorectal tumor samples and normal colon samples taken from patients after surgery. The idea here was not to find the boundary of colon tumor. This is not a relevant task in colon surgery, but rather to correlate metabolic parameters with tumor prognosis, to find such parameter that would better correlate with tumor prognosis. What we see here, this is fluorescence intensity images, no differences between tumor of T3 stage and tumor distant colon. You see here FLIM images of FLIM images of the ratio of the short and long components of an ADH decay, that is free and bound in ADH ratio, and histological images just to confirm that tumor is tumor and normal tissue is normal tissue. We found that the free to bound ratio of an ADH is lower in the tumor in comparison with normal colon, which is also interesting because it is contradictory to a common view on the tumor as glycolytic tissue. So when we are comparing tumor and normal tissues, we should keep in mind that normal tissues also different in their metabolism. It depends on the tissue type, on the function of this specific tissue type. So tumor here seems to be more oxidative than normal tissues outside. And I would like also, what I also would like to stress here is metabolic heterogeneity of the tumor at the cellular level. So this diagram shows how big is the dispersion of a 1:2 ratio, free to bound and ADH ratio in the tumor samples in comparison with normal. So dots here are the measurements for single cells, and each column here is a measurement for one patient. So heterogeneity is high. Any heterogeneity in the tumor is a bad prognostic factor because the many phenotypes are in the tumor, the many chances it has to develop resistant to therapies. So in our plan is to correlate metabolic parameters detected by FLIM, including heterogeneity, the degree of heterogeneity, with tumor prognosis for these particular patients.
Marina, this is a 5-minute notice.
Yeah, sure. Now I'm moving to the second part of the talk about monitoring of tumor response to chemotherapy. At the beginning of this study, we tested if it is possible to monitor the response of cancer cells to therapy, to chemotherapy, using FLIM of NADH and the redox ratio of AD divided by NADH fluorescence intensity. Here we monitored the same cells in the same field of view during a long time, 2 days after the treatment with cisplatin. Cisplatin is alkylating agent which targets cellular DNA. We found that a redox ratio increases in cancer cells after the treatment, and this perfectly correlated with the inhibition of cell growth. We also monitored fluorescence lifetimes in the same cells. We didn't see any differences any changes in T1 and T2 values by did for free NADH fraction. Free NADH fraction decreases in the tumor quite early after the treatment, after adding the drug, and this decrease in free NADH contribution indicates about a shift from glycolytic to more oxidative state, and is also correlated perfectly with decreased proliferation. And we also confirmed this in vivo by doing FLIM of NADH again. So we did these measurements at the final point of the treatment, when the differences between tumor sizes of treated and untreated tumors were evident and histological alterations already seen. So we also see here in vivo that treated tumors have decreased contribution from free NADH, indicator of oxidative metabolism, oxidative shift. So next we did the same things with another drug, paclitaxel. Paclitaxel is an anti-microtubule agent that blocks mitosis of cancer cell, principally different mechanism of action, but quite the same changes, increasing the redox ratio and decreasing free contribution of NADH. But what we see here is that paclitaxel induces heterogeneous responses in the cell population. We saw here 3 subpopulations of cells: viable cells with unchanged morphology, viable cells with altered morphology, and dying cells and more responsive. Dying cells developed metabolic changes earlier than all the other cells in the population. And finally, we did in vivo study on colorectal cancer model with different drugs used for in the clinic to treat these types of tumors, cisplatin, paclitaxel, and irinotecan, and found that similar changes occur in the tumor irrespective to the mechanism of the drug actions, decrease in the free NADH fraction shown here. And these changes developed quite early, before any morphological changes occurred in the tumor and before tumor inhibited its growth. This also can be done not only with microscopy, but also with fiber-based system. So we had such a system with a needle probe that can be inserted into the tumor. And from our point of view, these techniques can be more relevant for clinical use, because biopsy in the course of chemotherapy is not allowed. So we see the same changes, decreasing the free NADH fraction after the treatment, indicating a shift to a more oxidative metabolism. So now, when we know that FLIM of NADH is a sensitive technique to metabolic changes induced by chemotherapy, the question arises how to use these results and this technique to test chemosensitivity of patient's tumor using FLIM, if it is possible to do. And the quick answer is yes. It is hard work, but it is not impossible. What you need to do is to take the tumor after surgery and establish a primary cell culture, add the drugs you need to test, and measure fluorescence lifetimes. You should keep in mind that the establishment of the primary cell culture is laborious and multi-step procedure. It's not easy to do. And all the primary cultures have very short lifespan. You can work with such a cells only within a few weeks. And maybe the biggest problem with such primary cultures is a weak adhesion to plastic or glasses. You can do nothing with fluorescent cells. But anyway, in our previous studies, just using MTT assay, standard viability assay, we found that different cell cultures obtained from different patient tumors indeed have different sensitivity to drugs. And as expected, different primary cultures from different patients have different metabolic signatures. For example, one of these 4 cultures was more oxidative in the metabolism according to A1 to A2 ratio. And finally, we tested the sensitivity, the response of the primary cultures to drugs, and saw the changes in their metabolism. So the response to therapy can be assessed by FLIM on the patient's material. To summarize, metabolic imaging based on the measurement of fluorescence intensity and lifetime of endogenous cofactor and ADH is highly sensitive, label-free approach to interrogate metabolism of cells in the cell culture and in the tissue. And this technique is capable to differentiate between normal and cancer tissue and sensitive to changes induced by chemotherapy. Therefore, it offers a number of opportunities to improve diagnosis and treatment of cancer. And finally, FLIM of NADH is not limited to models of cancer, but also can be applied to patients' tumors, as I showed you, which means that more accurate information about metabolism can be obtained, which is important from the fundamental point of view. And so clinical translation of the method is not far from reality, as you see. I would like to acknowledge my group, my colleagues who contributed to all these studies, and I would thank our collaborators from the clinic and Becker-Hickel Company and Russian foundations for financial support. And thank you very much for your attention, and wishing you warm and pleasant weather in your city. Thank you very much.
Thank you very much, Marina. We have one question I would like to relay to you, and that is Austin is actually asking how much power you used for those measurements in vivo, and which effect it would otherwise have in short and long term.
How much power?
Correct.
Normally, we use no more than 6 milliwatt power. It is not invasive. It is safe, absolutely safe for the tissue. And from our experiments, the fluorescence lifetime and the ratios of the short and long components doesn't depend on the power that we apply, because we work with a very small light powers, I would say.
All right. Thank you very much. Marina, thank you very much for everything. It's a very great talk. Again, for the audience, I encourage people to ask their questions through the chat function to Marina, who will remain available.